So I think the question that we first got online is one that comes up very quite commonly on our support line, and I'm sure you hear it in clinic as well. But are there any aspects of the WM disease that are hereditary? Don't know who wants to take that first.
So there's no single gene that we know of that we can test for that we know is going to predispose people to WM, but we know there is probably genetic susceptibility to it. So we can't tell you what the genes are, but when we look at big population studies, when you look at a big group of thousands of people with WM or other lymphomas, and look at their first-degree relatives, so either brothers, sisters, children, parents, compared to a general population, they're about 5 to 10 times more likely to also develop either WM or another lymphoma. So it's still very, very rare, because 5 to 10 times the chance of a rare disease is still a rare chance, but there is some genetic susceptibility.
Should we go to the question in the room there?
Yeah. I was at the session for active monitoring, and one of the things that I'm very newly diagnosed, just a few weeks, and one of the things that I read about is that, unlike a lot of other cancers, it's not a question of you have to do something immediately, but what are the urgent or emergency sort of situations that can arise? And watch and wait or active monitoring in the early stages?
So in terms of patients with first presentations with WM, I think probably the hyperviscosity is one that is probably the sort of the emergency of WM. So that's the sort of situation where a patient might present with symptoms, and we would arrange an urgent admission and urgent treatment and assessment. The other probably main, most common urgent or new indication for treatment it will be a new severe anemia. So a patient presenting probably with an anemia that's come on over a long period of time, maybe even several years, but that being like the first time that blood test is checked. So I think for me, those are probably the two most common, or the two kind of standout situations.
But I think when you're on active monitoring, then those situations will be never, never say never, but they should not be acute, because you can see them coming. So sometimes people come in because they didn't know they have Waldenstrom, and then they present with deep anemia, and it turns out to be Waldenstrom. Well, no one could have known. But once you're being monitored, we're not going to wait until you have deep anemia or hyperviscosity, because you're going to be treated way before that. So,
absolutely. We would, with active monitoring, we'll absolutely avoid the need for urgent treatment. Yes. With active monitoring, we'll see a trend over a long period of time and have plenty of time to discuss options rather than have that urgent situation. Absolutely. Yeah.
It's not the disease that changes from one day to the other, usually.
Just to add, what is probably most dangerous, I completely agree. So normally this is monitored and it's not so dramatic. But what you should take really seriously are infections. So infections are the driving force of mortality. Yeah, so you don't die normally on hyperviscosity, or hemolysis can be dramatic, but infections. So take fever always very seriously. So because you are, based on your disease, in a high-risk population. So when you have fever and you're feeling well, Christmas evening, you take it serious, you go into the hospital. When you have a general practitioner or whoever who's not so familiar with this and wants to give you oral antibiotics, be skeptical. So when you really feel bad, high fever, it's always something different than when you would not have Waldenstrom. And so this can be deadly. And this is what I always tell my patients. It's like this, just take it seriously and then it will work well.
Thank you. I think we'll move on to another online question here. So this one's specifically about treatment and why rituximab and I guess other treatments are tolerated by some patients but not others.
Shall I go for that one maybe? So rituximab is really widely used in all B-cell lymphomas, of which there are hundreds of types, I think now. I think Waldenstrom's is a very it produces an inflamed climate in the system. There's extra antibodies being produced, quite a few kind of inflammatory chemicals circulating in the body. So when you introduce a therapeutic antibody like rituximab, it somehow can trigger off a cascade of inflammatory effects. And for sure, we see more reactions to rituximab than I've seen in any other forms of lymphoma. And we know also that there is this flare phenomenon where if you have an IgM paraprotein of like 30, 40 grams or higher, you're very likely to have a flare in your IgM, which can last weeks and months even, and could push you into a hyperviscous state. So I think it's probably related to the inflammatory climate, for want of a better word, within WM patients. I don't know if anyone has any other thoughts on that.
I think just as a general point is that we don't know why some people's disease responds to certain drugs and others don't. And similarly, the side effects as well. We tell you about all the potential side effects that may happen with the drug, but some will get some will get more or fewer. And honestly, at this moment in time, often we can't tell you why.
We do know, I don't know, maybe you said this, but the acoustic is a bit difficult with the stage. But we do know that Waldenstrom patients have a lot more intolerance for rituximab than people with other lymphomas, probably due to the things we were explaining with the, but it's not necessarily everyone. Most patients tolerate it well, actually, in my experience, but yeah.
And I think the other thing to say is that rituximab is a very important component of chemoimmunotherapy. So it's certainly in our practice, we don't give up easily if someone has a reaction. We obviously follow the protocol, go slow, stop, reintroduce, etc. But even if there's been quite a serious reaction, we will plan an admission to try and get the rituximab in, because usually people respond less dramatically as time goes on. But sometimes we've admitted patients for every rituximab infusion, because I think if you're going down the chemoimmunotherapy route, rituximab is really important to be part of that recipe, if you like.
So just as a side note, so one tool to downregulate this intolerance, it's an expensive tool, is to give ibrutinib. Yeah, so we know that when you add ibrutinib to rituximab, these kind of reactions are much less than when you give rituximab with, let's say, with other drugs such as chemotherapy. Just underlines what you're saying, because ibrutinib has also the effect to dampen the inflammatory milieu we see in Waldenstrom. So it increases tolerability to rituximab, but of course it's just a side note, so you cannot start ibrutinib because of rituximab reactions. So.
Fantastic. Thank you so much for that in-depth response. And I think we've got a question from the audience.
First of all, I'd like to say thank you very much for the presentation. Fantastic. I'm here. My wife is back in Nottingham with WM. And one of the things she would have worried about was coming into an audience. So you mentioned about infection, and obviously we had COVID, and there is still COVID. There's probably somebody in this room that has COVID. And my wife would say she probably won't go to the theatre where she's sitting close together. She worries about going on an airplane. She wears a mask. It's that concept of infection being all around you and the risks to you, potentially with WM, of getting COVID as a prime example. That is a worry that stops her maybe enjoying life like she used to live before she had COVID. I just wonder what your thoughts were.
Yeah, I think it's definitely understandable that infections are a major problem in WM. I would say that we're now living in a climate where there's vaccinations, and we're really fortunate to have access to those, and we would promote all of our patients to stay vaccinated and encourage. We know that the more vaccinations patients have, the better protection there is. And it's always a balance for how much you can do getting on with your day-to-day life. We really try to promote people staying as active and kind of engaging with as many activities as they can. And we try not to prevent normal activities. So it is sensible if you're having chemoimmunotherapy to avoid kind of places where there's people will be coughing and with diarrhea and other things. But I think we try to encourage people to engage and get out and stay active, because that's really important generally for your health. And as much protection as we can, which is vaccination. We also give antimicrobials and antiviral medications if you're on certain chemoimmunotherapy regimens, and having a good discussion with your treating team, because the anxieties of getting infection are real. But I think if you can have a good discussion with your team about things that you can do, it's probably helpful, because a lot of these anxieties can be relayed and can be addressed. Because I think it's more important that you're active and you're able to enjoy a good quality of life. Otherwise, the danger is you can really restrict a lot of things that you'd want to do in your life.
Well, I always say in the end, we don't treat you to then spend the rest of your life at home, right? So there's a balance in these things, I think. Do you revaccinate? So we tend to do a complete revaccination, for example, for COVID 1 year after rituximab, because it sort of wipes out the memory response. But I don't know if that's done routinely.
We're not routinely revaccinating following rituximab, but because patients are having regular COVID vaccinations anyway, in effect, they're being revaccinated all the time.
So keep getting them.
So they keep getting the COVID vaccines. But yeah, completely echo what Jahanzib says. I mean, at the moment, WM is a chronic disease. You're going to live with it for the rest of your life. So we want you to live for as long as possible, but also good quality life as well, and do the things that you enjoy. And infection is really an important part of reducing the risk of infection, but also still doing the things that you enjoy is really important as well. So having a good discussion with your clinician, depending on where you are in your treatment pathway, about those risks and what you can do to modify those risks is really important.
Yeah, because there's definitely different levels of having an impaired immune system, like completely low immune system, intermediate, pretty good, and there's also a big difference between those groups.
Brilliant, thank you. I think that's so important about getting that balance right between, good quality of life and looking after your health. So moving on to another online question here. This is about GPs. So I guess for the panel, the European, I guess it's primary care in general. But how can we help our primary care practitioners understand WM nuances? So I guess that's really interacting with those healthcare professionals.
That's quite a challenge. I think there are some hematologists who haven't seen much WM, for one thing, and then there's general physicians, and then so GPs being in primary care. I think they have really the toughest job in medicine, actually, because they have to see everything that comes through the door, and they don't have as many investigations to hand as we do in a hospital. So I think it's a huge challenge, and medical knowledge has gone through the roof. So they have to, their knowledge base keeps expanding by the minute, I think. So I don't know, we've grappled with this a lot in the WM community because of the rarity of WM. And I think how to target GP specifically, I don't know, because I think they're completely drowning. I think rather a top-down approach where you speak to the treating community and make sure the message is passed about WM and the treatments and so on, but also speak to the patients, empower the patients, and let them advocate for themselves and provide information that they can take with them so that they can sort of say, look, I've got this is what I need to do, and encourage them, the GP maybe, to get in touch with the hematologists who are looking after them and sort of just create a dialogue. I know this is all very well because in the busy world, people don't really have much time, but from my perspective, I think engaging with clinicians when they reach out is a really good way, because they then get more invested in that case and they get more interested. And I think it's kind of winning the hearts and minds. But doing that one GP at a time is not that efficient.
Yeah, I think for GPs, there's the piece about diagnosis, and we heard Ellie's story about having to go back repeated times with the tiredness. And, my sister's a GP, and the number of people she gets that comes with tiredness to her all the time, and she has to find the one patient in so many thousand who has WM or another underlying condition causing it. It's hard for them, but kind of giving them the information to help them decide when do these patients need extra investigations is really important. So I think education about diagnosis. I personally don't think that their job and role is to become experts in WM. Most GPs won't have a patient with WM, and they will have lots of patients with lots of rare diseases, so they can't be experts in everything. But knowing when the diagnosis pathway is important, but also understanding that some of the drugs that we give now, that many of you are going to be on for many years, like the BTK inhibitors, also increase the risks of things that they do deal with a lot, like the high blood pressure, the irregular heartbeat. So giving them advice about, we're starting a patient on ibrutinib or zanubrutinib, these are the risks, please can you look out for and treat, because they will be better at keeping up to date with the best drugs to give for the high blood pressure than potentially us.
But probably it's also country specific. So in Germany, actually, so the Waldenstrom patients are cared for by hematologist oncologists. So the general practitioner, of course, has the job to diagnose. Probably it's not happening, but we heard there's a watch and wait period. So let's say you have symptoms, then the private practitioner will refer to a hematologist oncologist, because he will do a blood count and so on. And then Waldenstrom is easy to diagnose because of the monoclonal IgM. They do a serum electrophoresis. So, and then the hematologist oncologists, at least in Germany, they know more or less what to do. I don't see it's a major problem, the general practitioner in Germany. I don't know, perhaps it's different in the UK, and they are more treated or cared for by general practitioners, but in other countries, also in France, it's really done then by hematologists, oncologists very quickly.
Okay, my name is Lars Evenuk. I'm from Norway. I have a question regarding to stem cell transplantation. What is your experience with regard to Waldenstrom, and when do you recommend this treatment?
Shall I?
We can all.
So, you want?
Yeah, well, I think it's there's two types: autologous stem cell with your own stem cells, which is a trick to give a lot of chemotherapy, and allogeneic stem cell transplantation, where you transplant donor stem cells as to transplant a new immune system to keep the disease away. Both of them are quite toxic, but the allogeneic is really quite a toxic and quite a dangerous treatment. Auto transplant is also something that we would not do over 65 or 70 years old. So a lot of patients, it's not the best option, because you have to be really fit and able to for the side effects to balance the effect. So we would never recommend it for first-line treatment, never ever. And then second line, probably also not, because as we heard, first and second line is usually chemoimmuno and BTK inhibitors. After that, it can become an option, autologous transplant especially, if you are a fit youngerish patient who's fit for that type of treatment. And my experience, we did it maybe a couple of times in my clinic for exceptional cases. And these people, the good thing about it, it's an investment, I always say, because they are, it's a lot of chemotherapy, and it will make you very tired for at least half a year or a year. But these people can remain in a very long remission. So it gives, especially for younger people, it gives you a very long interval where you don't need treatment, which can be nice. So pros and cons, and definitely not a standard treatment for Waldenstrom, but it's one of the fruits in the basket that we can choose from sometimes. Yeah. allogeneic stem cell transplant, I think in only very, very exceptional cases. I can't remember the last one that we did. I would rather look for clinical trial in those cases. But I don't know if my colleagues agree. There's a lot of debate. So
I think before the advent of BTK inhibitors, it was something that was called upon when people were not responding to standard dose chemotherapy, because it was, you upgrade, you make it more intense. And in order to deliver the chemotherapy, you collect stem cells beforehand, and then you return the stem cells to the patient, and hopefully that intense chemo can squash the disease. It's not regarded as a cure, but I mean, sometimes if a patient's disease, if the patient is young and their disease is behaving a little bit stubbornly, if you like, I personally do discuss it with them, because the BTKI journey is a long one. I mean, it's a long, you've got to make space for a long journey in this disease. So if someone is in their early 40s and you're already running into second-line therapy, although BTKIs are extremely effective drugs, I've also seen that side effects can accumulate. So we have a very frank discussion about what people also prefer, not that they can really say it because they've never had it before, but I think it may have a place, but certainly not up front, but there may be a role in some circumstances. If the disease becomes more aggressive, transformed, then it perhaps has a greater role, although there are some newer therapies for transformed disease as well. So yeah, it's, I don't know, if you have any views.
I think just in the rarer situation where you have complication of amyloidosis related, then that's something that will definitely be discussed and should be thought about, because really that's a situation where you want to get as deep a response or as much effective therapy in as possible. Obviously that's a rarer complication, but that's where it would be indicated.
yeah, but it's true. In those two situations, you would do it even first line. Yeah.
Yes.
Right.
Thank you. I think we've got another question in the room now.
Yeah, first off, thank you for everything today. It's been a great day. Thank you. So my question is, when you're diagnosed with WM, living with WM, it can be a bit scary, be a good word. There's a lot of things to worry about in terms of, when am I going to get treated? How's the treatment going to go? How am I going to live with this? How am I going to live with that? All these kind of things. So how can we ensure that a patient's mental health was given the same level of care as their clinical health, particularly during active monitoring, first diagnosis?
It's quite difficult to hear the question.
No, it's about mental health when you're first diagnosed.
Would you like me to repeat it?
So I think the question was about when you're first diagnosed. There's a lot of anxiety unknowns about when you're going to be treated, how it's going to fit in with your life, and how things might change. So how can we take priority of other things apart from kind of the physical health? I think it is tricky in a cash-strapped NHS system. I think that, to a certain extent, cancer treatment has been protected from some of the problems that we have in other parts of the NHS. When you look at waiting lists for other medical issues, it's tricky. And so, but we do struggle in terms of psychological support services in all hospitals, including some of the richer hospitals that we work in as well. So I think being well informed is a good start. So understanding the disease, I think helps with the mental health side of things. Knowing where you can go for extra support outside the NHS services if your hospital can't provide things within their service. So WM UK can potentially signpost you to places where you might be able to get that support. I think good living is important as well. So you've had the talk about exercise today, good diet. We don't know that these are going to change the underlying WM, but they will make you feel better and improve your mental health and probably help you tolerate treatments better whenever you may need treatment.
Right, thank you. So I think this one followed on from the peripheral neuropathy session. So if you let your feet get cold, could this make things worse for peripheral neuropathy? And connected to this, would hot or cold compresses be beneficial to relieve nerve pain? It's quite a specific one, but...
So when you have peripheral neuropathy, the sensations can be altered in different ways. Sometimes it's numbness, sometimes it's pain, tingling. The influence of temperature is an interesting one. Sometimes people have very exaggerated sensations when their nerves are not working very well. So instead of feeling, it's very binary. So usually you can feel gradations of change, but if you have a neuropathy, sometimes you go from 0 to 100, sort of just like that. So you think, it's a very exaggerated, quick change. One quick point about cold feelings is that sometimes the IgM can have an activity called cryoglobulinemia. So if you have recurrent feelings of coldness, temperature intolerance, hands, feet, nose, ears, if you get color changes, blotchy changes in your skin in the cold, then you should probably have a cryoglobulin test just to be sure that that activity is not present, because then there are ways of managing that. But in general, I think it's a bit of a trial and error thing. If you have associated numbness, then you need to be very careful about looking after your feet, because if you're numb, then you can't sense temperature. So you have to look and check that your feet are not getting damaged. Likewise, just making sure your toenails, all of that is looked after and that there's no problem developing there. But I think if you're unsure as to what's going on, you probably need a neurological assessment and nerve conduction test so that one can understand what the nature of it is. And, it also depends how quickly it's changing and how much it's interfering with your day-to-day life as well.
Great, thank you. So I think there's the next one here. After 6 years of diagnosis, I've developed dizziness and neuropathy. Does this indicate progression of the disease and then treatment, even though with the lab results are generally stable? So I guess it's about progression of the disease versus, stable blood tests.
I think Shirley, you can answer this, but neuropathy, we touched on this in the amyloid session, can be challenging because there's lots of causes of neuropathy. So it's important to look for other things like diabetes, some vitamin levels, nerves can change with age, medications can cause problems with nerves. So it's really important to keep a really broad mind when you're investigating these things, to look for engaging with the neurologist as well as the hematologist to try to find exactly what the thought of the cause of the neuropathy is, because it's not always the case that neuropathy is a sign of a problem with the WM or the IgM disorder. I think it's really a joint decision with the neurologist as well as the hematologist as to pinpointing the cause. And of course, if there is the cause of progression, then that can be managed.
And I think dizziness depends what it is. Is it in your head? Is it to do with the room spinning? Is it wobbliness? Is it fall in blood pressure when you stand up? Because these may have different causes. And also just anemia can contribute to dizziness. If you're running a lowish hemoglobin, that doesn't help either. So I think from our point of view, I think we would, if it's a persistent problem, then we would consider possibly like amyloid and stuff like that as well. But
yeah, I was thinking too, it depends on what you call neuropathy, right? Because it can mean a lot of things to a lot of people, and the same as for dizziness, but this combination of symptoms could potentially also mean Neal syndrome. If dizziness is being, like spinning news, etc. Yeah. It could be, but it could be tons of other things. So I think if these signs, if they persist, then a neurologist should study your symptoms and see what's going on with the knowledge of the fact that you have Waldenstrom as well.
If it's, on the other hand, more of a vertigo where the room is spinning, then that could be more of a middle ear problem.
Exactly. It could be something completely unrelated to the WM.
Sometimes it's a benign thing, benign positional vertigo, which needs maneuvers to help improve. So it's down to the details and an evaluation.
Fantastic, thank you. And I think this one's following on from your session, Josephine. Where can we find out about the progress and results from clinical trials? So I guess you showed us how we can take part in them, but how do we find the results out?
That's a really great question, because if you participate in a clinical trial, you also want to find out what it led to in the end. And it may take many years, because very often clinical trials have a long follow-up. It might be, so from the moment that the last patient enters the trial, you may need, for example, another year before they reach their primary endpoint moment. So if you're one of the first patients to enter, and it took 3 years to find all the patients, you may have to wait 4 years before the trial's finished. Then the researchers have to analyze all the data and make reports out of it. It may take another half year. So it can be many years before the final results are available. But in every clinical trial we do, at least in Holland for our ethical committee, we have to state how we're going to report back. And usually we do it through the patient organization. So we will say, in Holland, it's called Hematon. So you can go to the Hematon site and we will update as soon as we have the results. Some trials send a thank you letter to patients at the end of the trial where it states where they can find that information. And of course, you can just ask your doctor, because in the end, there will be a publication that's in a medical journal, or there will be a presentation at a big conference, so your doctor can also help you with that.
Great, thank you so much. I think we've got one in the audience just there.
Hi, thank you for an excellent forum all round. I'm very impressed with everything you've done. My question is just a general one, really, because one of the panel members was saying earlier that the aim, objective ultimately is like a magic bullet or a pill where you just swallow and no side effects and the disease is cured, which would be wonderful. But and I'm sure you're going to hedge your bets in trying to answer this question, but can you give us some idea where we're going and what the time scale is for getting more effective treatment? Because at the moment, most of us will go on some sort of immunochemotherapy that will last for a few years, and we have to go back, and then so on and so forth. So what can we look forward to? And how would that affect people depending on what their age is now? Because some people will be too old to benefit, I guess.
I think I'm the one to blame for that slide.
No,
And it's hard to have
Christine to answer.
the same slide, right? You had also one about a magical pill. Yes.
We nominate you.
Yes.
Of course. Of course, it's difficult to say. But, first, our vision is to cure the disease. I think this is a very clear statement. So all we are sitting here, this is our vision. Yeah, and of course, you're right. At the moment, there is no cure in the pure definition, cure. What we can achieve already at the moment is in many, many patients like functional cure. So you are not dying anymore of your Waldenstrom, but by something else. So you are dying with your Waldenstrom, but you are not dying because of Waldenstrom. So this, I think, is already reality in many, many patients. So functional cure. So I think the next step is to achieve this functional cure with the longest possible treatment-free interval. So this is the next major step. So with the idea, exactly what you said, not being treated all the time, but very time limited, and that you have very long time without any treatment. So this would be still not cure by strict definition, but it would get you close to a situation where you are more or less all the time treatment-free, you have a normal quality of life, and you die, we all have to die, by something else. And I think this kind of functional cure we can achieve realistically probably in the next 5 to 10 years, because what we see with these new immunotherapies, the bispecifics, and also CAR Ts, I think there is a huge potential promise, at least, that we achieve this goal. And, I think it will be not a black and white development. There will be no magic bullet, but it will be an evolution where at some time point, Waldenstrom is treated once and that's it. or perhaps twice in your whole career, and that's it. Yeah, and so I think this is the way probably we have to think and how we will develop. And as said, I think we are in 5 to 10 years very close to the situation based on an amazing tool of new drugs. You have to imagine at the moment, so Josephine is testing one bispecific. There are at the moment over 200 in development. Not preclinically, but clinically. So there's a huge dynamic, and I'm very optimistic that we achieve this goal soon.
And there's another group of drugs called the BCL2 inhibitors.
Many others. So
Rotaclax, there are trials ongoing at the moment.
Absolutely.
And I would say, before we could prescribe ibrutinib here in the UK, we reached a wall when people didn't respond to chemotherapy anymore. And suddenly ibrutinib provided a lifeline to people. And there have been successive of ibrutinib, which are better tolerated. And there's talk about combining things and the new agents on Rotaclax, which is a BCL2 inhibitor. So it's really an ongoing march, which I think is unstoppable. Every patient is different, and one of the focus of research is to see how the different diseases differ in different people, and where to how to target them. But I mean, whenever I meet a WM patient the first time, I'm honestly very optimistic that they have to live with this. It's a chronic disease that they're living with for the vast majority of people. And yes, one has to be strategic about using treatments in the right way for the right patient. But I think on the whole, this operational cure is getting closer and closer every single year, I think.
Thank you. And then we just got time for one last, I think it might be a quick question. She says, optimistically, is it still recommended to seek post-viral drugs that can test positive for COVID?
So,
yeah.
So that the advice we give our patients with WM is if you do test positive for COVID, then we have a helpline which is dedicated to assessment of patients with COVID, with the aim then for early supply of Paxlovid, or if there's a drug interaction which precludes that, the alternative is molnupiravir. So we know that the use of Paxlovid really reduces the severity of infection and reduces the risk of hospital admission significantly. So we do still advise the use of Paxlovid. Yeah.
Thank you. So that's it for our healthcare professional panel for today. Huge thank you to all our healthcare professionals who joined us and gave up their time for us today. Really, really appreciate it. And I'm sure everyone will take away so much information and support within that. So thank you so much.